A scalpel is only as precise as the hand that holds it. A robot changes that equation. Surgical robots are no longer futuristic curiosities. They're part of everyday medicine. More than 7 million procedures have been performed with the Da Vinci system since its approval in 2000, and for certain operations, the ones where precision shapes the rest of a patient's life, robotic assistance has become the standard. To understand why, step inside a robotic prostatectomy. The surgeon sits at a console, looking into a magnified 3D view of the pelvis. The robotic instruments move with millimeter precision. The camera never trembles. Inside the body, the prostate is wrapped in nerve bundles that control continence and sexual function, fibers so delicate that a few millimeters can change a patient's future. And the difference shows up in the outcomes. Studies show robotic-assisted prostatectomies preserve sexual function in roughly 75 to 80% of patients, compared to 60 to 70% with traditional open surgery. Urinary continence returns for 90 to 95% of robotic patients within a year versus 80 to 90% with open approaches. Patients lose less blood. They go home sooner. These aren't marginal gains. They're the reason robotic prostatectomy became dominant in many wealthy countries. But the story is shifting again, from mechanical precision to machine interpretation. AI systems are beginning to analyze what they see during surgery. Medtronic's Touch Surgery platform, now used in several US and European hospitals, applies computer vision trained on thousands of surgical videos to identify anatomical structures in real time. During a prostatectomy, it can outline nerve bundles on the surgeon's screen, a subtle overlay designed to protect the structures that matter most. Active Surgical's Active Site system goes further. It doesn't just highlight anatomy. It tracks blood flow and tissue perfusion, warning surgeons when tissue isn't getting enough oxygen. In colorectal surgery, where maintaining blood supply to reconnected intestines is critical, this kind of real-time feedback could prevent complications that lead to repeat operations. These systems don't make decisions, they provide information. The surgeon still controls every movement. But as AI becomes more capable, a familiar tension emerges. Automation bias, the tendency to trust machine outputs even when they conflict with human judgment, is well documented in aviation and radiology. A 2019 study in JAMA found that radiologists were more likely to miss a cancer they initially spotted if an AI system didn't flag it. The same risk exists in surgery. If a surgeon sees something concerning but the AI stays silent, which instinct wins? The human or the machine? And if the AI is wrong, who carries the responsibility? Under current FDA guidelines, AI surgical guidance is classified as clinical decision support, which means the surgeon remains legally responsible for all outcomes, even when following AI recommendations. But as these systems become more sophisticated and more trusted, that framework strains. If an AI trained on 100,000 procedures contradicts a surgeon's instinct and the surgeon overrides it incorrectly, the lines of accountability blur. There are no clear legal precedents, no settled framework. Just questions that hospitals, insurers, and courts will have to answer one case at a time. And then there's access. As of 2024, there are roughly 7,500 Da Vinci systems worldwide. More than 4,000 are in the United States, a country with less than 5% of the global population. The entire continent of Africa has fewer than 50. Nigeria, with 220 million people, has 2. Even within wealthy countries, the distribution is uneven. A 2022 analysis found that 80% of robotic surgical systems in the U.S. are concentrated in urban and suburban teaching hospitals. Rural hospitals, serving nearly 20% of Americans, have minimal access. AI-guided surgery is becoming a premium tier of care, available in major academic centers and private hospitals, out of reach for most of the world. The benefits are real. better outcomes, fewer complications, faster recovery. But those benefits are not evenly shared, and the gap is widening as the technology advances. Because the robot isn't the story. The story is the fork in the road. And whether the partnership between human judgment and machine precision becomes standard care everywhere, or whether it remains concentrated in the places that can afford it, leaving everyone else with older tools and narrower margins for error. That choice isn't abstract. It's being made quietly right now, in procurement meetings, training budgets, and insurance policies. And the surgery happening tomorrow will reflect the values we decide on today. If you want to follow the choices shaping tomorrow's care, you're welcome to subscribe.